Chapter 35, Anti-Cancer Drugs. So we're going to talk about the anti-cancer drugs, also called chemotherapy agents. Cancer drugs are powerful because they are designed to kill cells that divide rapidly. The problem is cancer cells divide rapidly, but so do some normal body cells like hair and the GI lining and the bone marrow. So a big theme of chemo is it attacks cancer, but it also causes side effects because it hits normal fast-growing cells too. So chemo is basically controlled toxicity, strong enough to kill cancer cells, but safe enough for the patient to survive. Influences are genetic mutations, inflammation, infectious organisms, it's environmental, even an unhealthy diet can cause cancer. So cancer is not just by one thing. It's usually a combination of influences, and then we'll just go through some of these. Genetic mutations are like the DNA changes that cause the cells to stop following the rules. Inflammation creates constant cell damage and repair, which increases mutation risk. Infectious organisms like viruses can trigger cancer. HPV is a big one, or a good example. Environmental factors like smoke and radiation, asbestos, and chemicals. And we talked about some of this in chapter 18. Unhealthy diet. So diets high in processed foods and low in antioxidants can contribute to cancer risk, something we don't think about a whole lot. Cancer often develops slowly over time, years of damage, inflammation, and mutation. So this slide is huge in understanding how the chemo works. So we're going to talk about cell cycle non-specific and cell cycle specific. So cell cycle non-specific drugs, they kill cancer cells at any phase of the cell cycle. They don't care what stage the cell's in, they just damage the DNA. So examples of this is the alkylating agents, the anti-tumor, antibiotics, hormones. Those are considered cell cycle non-specific. The cell cycle specific, these only work during certain stages of cell division, so the timing matters. And some examples of those are the anti-metabolites and the alkaloids. So the reason we use combinations is because we want to hit cancer cells no matter what stage they're in. We've talked about this a little bit in the other chapter, but just to reiterate cancer chemotherapy, there's the adjuvant, the neoadjuvant, palliative, and protocols. So adjuvant therapy, this is the chemo given after surgery to kill leftover microscopic cancer cells. The neoadjuvant therapy is the chemo you give before surgery to shrink the tumor first. And then palliative chemotherapy, this is not meant to cure, it's just meant to improve the quality of life, like reduce pain, shrink tumor burden, or relieve symptoms. Like sometimes maybe somebody may have a tumor pressing on a nerve and they shrink it just for to ease the pain. Protocols, chemo is not random, so there are standardized treatment plans based on what type of cancer a patient has. Palliative care does not mean giving up. It means shifting the goal to comfort and quality of life. And I'm going to say that again. Palliative care does not mean giving up. It means shifting the goal to comfort and quality of life. Combination chemotherapy is where using two or more of one drug together, and the reason they do that is it enhances tumor killing, targets multiple phases of the cell cycle, and it works better with that synergistic effect. They work better together, and it decreases the drug resistance because cancer cells are smart and they adapt. Using multiple drugs prevents the cancer from basically outsmarting the medication. So general side effects, it affects normal cells, skin and hair, GI tract, mucous membranes, bone marrow. Chemo affects normal, fast-dividing cells. So it's often given now in outpatient. Patients go home the same day. A lot of times they're getting their reports and they actually do their chemo at home sometimes. So some occupational exposure is a big nursing safety issue, so you want to make sure that we're teaching our patients to wear gloves, gowns, and proper disposal, because we treat chemo like hazardous waste. Kind of scary that's going in your body, right? If chemo suppresses bone marrow, then what's the number one life-threatening risk? Would be infection, right? So alkylating agents are some of the oldest chemo drugs out there. They damage DNA, which is the blueprint, so the cancer cell can't reproduce. These drugs are powerful, but they're very toxic. And classes listed are just categories, but the key is they all attack the DNA, basically. So if you hear alkylating agent, just think DNA destruction. So an alkylating agent, cyclophosphamide, is one of the most common alkylating drugs. It's given PO or IV. It's a severe vesicant. If it leaks into the tissue, it can destroy the tissue. So a big NCLEX point to make is hemorrhagic cystitis. The bladder lining can bleed and become inflamed, so hydration is extremely essential with this drug. Encourage patient to drink fluids and possibly give Mesna if ordered. Some side effects that we need to emphasize is bone marrow suppression, so they're high risk for infection, alopecia, GI upset, the SIADH is possible, and tumor lysis syndrome as well. Okay, the concept basically here is immunity because chemo suppresses the immune function, so just recognize cues like basic labs, baseline physical status, and you can't safely give chemo without knowing the WBCs, the platelets, the kidney function, so all that needs to be evaluated. I mean, we need to assess baseline labs because chemo can take a patient from stable to neutropenic very quickly. Okay, so going further, just some things to remember. We need to monitor labs, especially the CBC and neutrophils. Monitor the IV site because it's a vesicant risk. Strict asepsis infection prevention is very important. Encourage small, frequent meals, nausea because of nausea and weight loss, and maintain hydration because of that hemorrhagic cystitis prevention. If a chemo patient spikes a fever, that's not a minor symptom and it's an emergency. So that's something that they need to report immediately. Antimetabolites, methotrexate is one of the most common. Interferes with DNA synthesis. They basically trick the cell into using fake building blocks. So methotrexate affects fast dividing cells, hair follicles, GI lining, bone marrow. It affects all of that. Also causes fetal cell apoptosis, so it's contraindicated in pregnancy. Methotrexate is used in both cancer and autoimmune disease because it slows down fast-growing or overactive cells. You'll see people with rheumatoid arthritis sometimes on methotrexate, or people with psoriasis. Another common chemo is 5-FU. It's an antimetabolite. It targets GI cancers, breast cancer, head and neck. Some key side effects is the stomatitis, mouth sores, bone marrow suppression, alopecia, hand-foot syndrome, redness and peeling. A thing to remember about 5-FU, patients may complain their palms and the soles of their feet feel like they're burning. So if the drug hits fast-dividing cells, what will we see? We'll see the mouth ulcers, diarrhea, and low blood counts. Going forward with the 5-FU concept is immunity because of the bone marrow suppression. We need to recognize cues such as conduct a detailed current medication history, obtain a list of drug and food allergies, and obtain baseline lab values is very important because chemo patients don't just have drug allergies, they may have hypersensitivity reactions. Continuing with 5-FU, monitor the IV site because of the extravasation possible. Asepsis, make sure that we teach them good hand washing because of neutropenic precautions. Antiemetic before chemo may help with the nausea. And so monitor INOs, cause dehydration risk from vomiting and diarrhea, and report infection immediately. Very important nursing concept. So why do we give antiemetics before nausea starts? Because prevention works better than trying to catch up after they get sick. Anti-tumor antibiotics, doxorubicin. It interferes with DNA replication and RNA transcription of the cancer cells. It is used in solid tumors and leukemias. Some side effects is the alopecia, stomatitis, the red urine, not blood, it's just the red urine is expected, so you want to let your patient know that. But chest pain is not expected, so they need to know about cardiotoxicity and dysrhythmias. They will probably be on a monitor. Continuing with the doxorubicin, perfusion is an important concept here, and heart function. We want to make sure we conduct a really good detailed medication history, obtain baseline data regarding patient's physical status. Some good teaching notes is just maintain strict medical asepsis during dressing changes and invasive procedures. Assess their cardiac status and check for any ECG abnormalities before and during treatment. Monitor that IV site frequently and stop infusion immediately if signs of extravasation are apparent. Handle the drug with care during preparation and avoid direct skin contact with this drug. Plant alkaloid, vincristine. It works by stopping mitosis. It blocks the M phase, so the cell can't divide. Some major side effect is neurotoxicity, peripheral neuropathy, constipation, and ileus, decreased reflexes. This drug can also cause SIADH. Vincristine doesn't usually damage the heart. It usually damages the nerves. So some concepts to consider, the sensory perception, we need a baseline neurostatus, assess bowel and urinary function because the nerves control elimination. If a drug causes neurotoxicity, what body system will it show first? The GI, mobility, and sensation. So they may have difficulty walking, they may have hypotension. Just read the rest of the slide. Normal chemotherapy means the drug is actually wrapped in a fatty coating, and this allows the drug to circulate longer and target tumors better. The benefits: less toxicity, fewer side effects, and improved therapeutic effect. Liposomal delivery is basically a slow-release protective capsule. Some encapsulated forms are the doxorubicin, daunorubicin, vincristine, and cytarabine. I'm just reading off the slide so you guys can take a look at that. Hormones and hormonal agonists and antagonists. Some cancers are hormone dependent, meaning hormones fuel the tumor growth. Breast cancer and prostate cancer are the big ones. So hormonal therapy works by blocking hormones, reducing hormone production, and altering the hormone receptors. So not all cancer treatment is kill the cell. Some treatments starve the cancer. So corticosteroids. Steroids are used in cancer for multiple reasons. They suppress inflammation associated with tumor growth, used for leukemias, myelomas, and also for symptom control. So some side effects, of course, we're probably familiar with is insomnia, mood changes, psychosis, especially if it's a high dose of corticosteroid, hyperglycemia, and fluid retention. Chemo patient on steroids may look better but still be immunosuppressed. So we need to keep that in mind. Sex hormones. Hormones can slow the growth of hormone-dependent tumors. Estrogen, progestin therapy may be used in certain cancers. Some side effects of these are thrombosis risk like DVT and PE, osteoporosis, and menstrual irregularities. So if hormones increase clotting risk, what symptoms should the nurse teach? Leg pain, swelling, shortness of breath, and chest pain. Anti-androgens and SERMs. So they block testosterone and estrogen effects. The SERMs, the selective estrogen receptor modulators, they act like estrogen in some places and block estrogen in others. Used mainly in breast cancer. SERMs are selective. They protect bones but block breast tissue stimulation. Luteinizing hormone-releasing hormone agonist. These drugs suppress the pituitary release of FSH and LH. That means less sex hormone stimulation. They shrink sex organs and slow hormone-driven cancers. So if you suppress LH and FSH, you suppress testosterone and estrogen production. The aromatase inhibitors block peripheral conversion of androgens into estrogen, suppress the postmenopausal synthesis of estrogen, and slows tumor growth. They treat hormonally sensitive breast cancer in postmenopausal females and premenopausal females with ovaries removed. According to this slide, vaccines stimulate T-cell immunity. The use prevent Hep B virus, which can cause liver cancer, prevent human HPV, which can lead to female cervical cancer and genital warts in males. So basically just some notes I have. Some cancers can be prevented. The vaccines stimulate immunity. Hep B vaccine prevents the liver cancer. HPV vaccine prevents the cervical cancer. So basically vaccines don't treat cancer, but they prevent cancer-causing infections. So a patient receiving chemotherapy for the treatment of cancer experiences stocking glove syndrome. The nurse identifies which drug class as most likely associated with this adverse effect. Plant alkaloids. The stocking glove syndrome refers to peripheral neuropathy, numbness and tingling in the hands and the feet, and that symptom is strongly associated with plant alkaloids like the vincristine. Remember, if it affects nerves, think vincristine. A patient is receiving the alkylating drug cyclophosphamide. Which of the following is most important for the nurse to provide? I forgot I could have at least read your questions to you, or your answers. A is IV hydration and assessment of fluid status. B is vigilant skin care and cleaning with mild soap. C is mouth care using half-strength hydrogen peroxide and a soft toothbrush. Or D, patient-controlled analgesia with mepridine. The correct answer is IV hydration and assessment of fluid status, because if you remember, the cyclophosphamide has that hemorrhagic cystitis risk where priority is hydration because it protects the kidneys and bladder. A patient's being treated for cancer is receiving medication for palliation. Which of the following does the nurse understand what palliative therapy is used for? A, relieve symptoms. B, kill tumor cells. C, decrease viral load. Or D, increase body defenses. And of course the answer is A, it relieves symptoms, because palliative care focuses on the pain control, breathing comfort, fatigue reduction, and those kind of things. So palliative therapy is symptom management. It's not curative, it's comfort based. A patient is receiving chemotherapy for the treatment of cancer. Of the following choices, which does the nurse anticipate nadir to occur? A, 2 days, B, 8 days, C, 15 days, or D, 30 days? The answer is B, 8 days. Nadir is the lowest point of white blood cell after chemo. It usually occurs 7 to 14 days after the chemo, and this is the highest time of infection risk. A patient is receiving cyclophosphamide therapy. Which statement by the patient indicates more teaching is necessary? A, I will take the medication before bedtime. B, I will eat a diet low in organ meats, beans, and peas. C, I may experience hair loss. Or D, I will not visit anyone who has a respiratory infection. Which indicates more teaching is necessary? The answer is A, I will take the medication before bedtime. Cyclophosphamide should not be taken at bedtime. It should be taken early in the day with fluids. That way the patient urinates frequently and flushes the bladder. Remember, we want the bladder emptied, not sitting full of toxic metabolites overnight. So that's the rationale behind that. The nurse assesses a patient who is receiving doxorubicin intravenously. The nurse determines extravasation has occurred. Which of the following is the first action for the nurse to perform? A, attempt to aspirate residual doxorubicin from the patient's vein. B, remove the intravenous catheter. C, pack the intravenous site with ice. Or D, stop the intravenous infusion of doxorubicin. And the answer is D, stop the intravenous infusion of doxorubicin. We have talked about that many times already, but stopping is always the first action that needs to be done. Stopping the infusion prevents more drug from damaging the tissue. So after stopping the infusion, you want to follow the facility protocol because there'll be a protocol in place. Leave the IV in place. Aspirate the drug, apply cold or warm depending on the drug, notify the provider. But basically you're going to follow your facility protocol. The big concept with chemotherapy is that it targets rapidly dividing cells. That's why it works against cancer, but it also explains why patients lose their hair, develop GI problems, experience bone marrow suppression. Nursing priorities focus heavily on infection prevention, bleeding precautions, hydration, nutrition, and early recognition of complications like extravasation and tumor lysis syndrome. So if you can connect the mechanism of action to the side effects, you can predict what assessments and interventions are most important. Thank you all for listening.